we actually? Sweet, awesome.
Okay,
Thank you so much for joining us for the defenses. This is always a fantastic moment for these students who have been working on these projects for often a number of years. And we were incredibly excited to be able to hear from Eden tonight. Just to give you a general sense about how the process is going to go. Eden will have about 25 minutes to present her thesis. At that point, her committee will ask a number of questions. And then once we get done with that, then the audience will get to ask a number of questions. So they really, really like it when you think of very difficult, challenging questions. So as you're watching the presentation, be sure that you are prepared for that. But we're going to be excited to hear what Eden has to say.
Okay. Hello, I'm Eden, and today I'm going to be discussing the effects of post-corporate healthcare and how the way we practice medicine has been affected. So this is When Profit Overrides Purpose, the challenge of post-corporate healthcare. Originally, this thesis was supposed to be a lighthearted conversation about how, as providers, we should make our patients feel seen and heard, and it's this really close relationship thing that we have. And will I be talking about patient-provider relationships? Yes, but is it going to be lighthearted like I thought it was going to be? Absolutely not. So today I will be analyzing the history of the medical profession. I'll be defining corporatization, evaluating the effects that corporatization has had on healthcare, and lastly, I will be discussing how corporatization is not just like the development of medicine, but it's a shift in power and an internal transformation in the values of medicine. I think the best place to start is by discussing this topic is to go back to the good old days to begin examining the history of medicine and the foundations it was built on. So to begin, in early medicine in the late 19th and early 20th centuries, it was centered around independence. Physicians typically worked in small local practices, and they built long-term relationships with their patients because they normally treated families. They would treat multiple generations of the same family in those local areas. And as Paul Starr explains in his book, The Social Transformation of American Medicine, this era gave physicians what he calls professional sovereignty, meaning they had full authority over medical knowledge and the decisions that they made. These medical decisions were made based on their knowledge and their ethical judgment and their understanding of the patient as a person, not just as a diagnosis. This allowed for a level of individualized care that aligned closely with the patient's circumstances, values, needs, things like that. As a result, trust became the foundation of the patient-provider relationship. Patients relied entirely on their physician's expertise, and physicians were held accountable directly to their patients rather than to an external system like we see today. However, as medicine began to expand, particularly with the introduction of new technologies, the structure of healthcare started to shift, and corporatization marked a subtle but very critical transition where autonomy was preserved in theory, but increasingly constrained in practice. So let's take a moment now to define what exactly corporatization is. Corporatization refers to the transformation of healthcare from a patient-centered profession into a system that operates using business principles. According to Aaron Fuse Brown from the New England Journal of Medicine, it involves applying corporate structures, financial incentives, and administrative hierarchies to medical practice. In simple terms, medicine begins to function less like a profession and more like an industry. This means that decisions are no longer based solely on clinical judgment, but they're also influenced by factors like cost efficiency, productivity quotas, and profit margins. Corporatization also shifts authority. Instead of physicians having full control over their medical decisions, that authority is distributed across hospital systems, insurance companies, administrators, and things like private equity groups. And that shift is very important because it doesn't just change how medicine is organized, it changes the logic behind how our decisions are made. Medical knowledge alone is no longer enough. It has to operate within a system that prioritizes financial and administrative goals alongside patient care. So when we're talking about corporatization, we're not just talking about bigger hospitals or more technology. We're talking about a fundamental change in the values and priorities that guide healthcare. And there's three main factors that I want to look at today when it comes to post-corporate healthcare. and that is technology, specialization, and insurance. Everybody's favorite topic. So with technology, throughout the 20th century, medicine saw rapid advancements in diagnostics, imaging, surgical procedures, and pharmaceuticals. These innovations have significantly improved our ability to detect and treat disease, and they're a major reason that modern healthcare is as effective as it is today. However, Paul Starr explains in his book that these technologies and advancements have also fundamentally reshaped the structure of medicine. As care became more complex, it also became more expensive and more dependent on specialized equipment and institutional support. Because of this, small independent practices were no longer practical. They were no longer able to sustain the demands of modern medicine. So hospitals and large healthcare systems became the central site of care, replacing the older model of your small local private like physician-run practices. So while technology has expanded what medicine could do clinically, it's also contributed to a structural shift away from independence and towards large-scale institutional health. Closely tied to technological growth is specialization. As medicine has advanced, the complexity of diseases and treatments has increased, requiring physicians to focus on narrow areas of expertise. This has led to development of specialties like cardiology, neurology, oncology, all of these different specialists that you think of, which has significantly improved the depth and precision of medical care. However, we know that this shift has also contributed to the breakdown of continuity in patient care. Instead of one physician seeing their patient for all of their needs, patients are now referred to different doctors across the board, each responsible for their own aspect of medicine. And while this improves technical accuracy, it fragments our care and reduces the consistency of the patient-provider relationship. Patients lose that long-term familiarity that they have when you have one provider caring for all of your needs versus having different providers care for certain aspects. It's caused the physician to not be able to understand the individual behind the illness. It's more of just diagnosing the illness, and there's not that personal connection really between the patient and provider. And finally, the major force in this transformation, again, everybody's favorite topic, insurance. As medicine has advanced through technology and specialization, the cost of healthcare has increased dramatically. Care that once took place in small independent practices has shifted into hospital systems that require expensive equipment, specialized staff, and institutional infrastructure. Because of this, it's become nearly impossible for most patients to pay directly for care or pay out of pocket. This gap has led to the rise of employer-based insurance and managed care. Those are just some of like the different forms of insurance. And they were originally designed to increase affordability and expand access to healthcare. At face value, insurance solved a major problem. It made medical care financially possible for millions of people who otherwise could not afford it. However, over time, insurance companies have not remained passive financial intermediaries. They became active participants in the medical decision-making. So today, insurance companies exert a significant amount of control over how healthcare is delivered through mechanisms like coverage determinations, provider networks, and prior authorization systems. And the most influential one that we're going to be talking about today is prior authorization. Prior authorization is a requirement imposed by insurance companies that forces physicians to get approval before a patient can receive certain medications, treatments, procedures, other diagnostic tests. In practice, this means that even after a physician has evaluated their patient and decided what the best course of treatment is, the decision cannot immediately move forward. Instead, the physician has to submit detailed documentation to insurance companies explaining why this treatment is necessary. And this documentation often includes clinical history, prior treatments that have been attempted, and justification for why alternative, usually cheaper treatments have not worked. And once submitted, this request is reviewed by not other physicians in a clinical setting, but by insurance reviewers whose primary role is to assess costs, policy compliance, and coverage guidelines. Only after this review process is complete can treatment be approved or denied. And in many cases, this process doesn't happen very quickly. It can take days, weeks, months, however long. And if the request is denied, then, the patient doesn't get that coverage for it. Physicians have an option to challenge that decision, but it requires a lot of additional paperwork, a lot of additional time, which takes away from them being able to treat patients. And sometimes, depending on who you're working with, that can put the physician or the provider in jeopardy. So now we're going to talk about the effects that it has on patients and providers. The impact of this system is not theoretical, it's measurable. The American Medical Association did a survey in 2024 asking physicians about insurance and prior authorization and how that's affected how they care for patients. And they found that 90% of physicians report that prior authorization delays patient care. Even more concerning, they found that at least 1/3 of physicians reported that these delays have led to serious adverse clinical effects. That can include hospitalization, permanent harm, in some cases, life-threatening outcomes. And beyond clinical outcomes, this process also affects the patient experience and trust. When patients are told that it's a treatment recommended by their physician, but it can't move forward because of insurance approval, it creates confusion and frustration for the patient. From the patient's perspective, care no longer feels like a direct relationship with their provider. It feels conditional and dependent on an external system that they don't see or interact with directly. This contributes to a broader sense of uncertainty in healthcare, where patients are aware that their treatment is not only determined by medical need, but also by administrative approval and cost considerations. Now, for providers, it also has a lot of effect on how they practice medicine. Physicians have reported that administrative burden of prior authorization is substantial. They spend hours per week, sometimes hours per day, completing all this paperwork that they have to turn in to get this authorization. And they're spending their time doing that rather than providing care. And after making clinical decisions, I just went back a page. So after making clinical decisions, and these physicians have to spend time, submitting all this paperwork, it shifts their role away from direct patient care and into administrative labor. The AMA survey that I mentioned previously highlights that physicians report spending substantial portions of their time completing these appeals, time that's not spent diagnosing, treating, or interacting with other patients. And in addition to the time burden, there's also a loss of professional autonomy. Physicians are trained to make decisions based on clinical evidence, patient history, and medical judgment. However, prior authorization introduces a system where those decisions must be validated by non-clinical reviewers who operate under cost and policy guidelines. And this creates structural tension in practice. Physicians may know what treatment is medically appropriate, but they're still required to delay care, change treatment plans, or submit appeals in order to obtain approval. A separate study done by the AMA also identifies administrative burden and loss of autonomy as a major contributor to physician burnout, showing that this process is not just inconvenient, it directly affects clinician well-being and job satisfaction. And over time, this repeated cycle of justification and delay contributes to frustration, moral distress, and burnout among providers, as they're placed in situations where they're responsible for patient outcomes, but don't have full authority over the decisions that shape those outcomes. We're going to move on now to a philosophical analysis of these changes. The more concerning question is the question of purpose, morality, and what medicine is supposed to be at its core. One of the most useful ways to understand what's happening in corporatized healthcare is through Plato's distinction between reason and appetite in the Republic. Plato divides the human soul into 3 parts. We're going to be talking about 2 of them here, between reason and appetite. Reason is the part of the soul that seeks truth, understanding, what's genuinely best. In medicine, that aligns with clinical judgment, the physician's ability to evaluate symptoms, interpret evidence, and determine the most effective course of treatment for the patient. Appetite, on the other hand, represents desire, things like money, efficiency, convenience, and material gain. Appetite is not inherently bad, but Plato is very clear that problems arise when appetite begins to rule over reason. In a well-ordered system, reason governs appetite, meaning that clinical judgment should guide decisions, while financial or institutional concerns remain secondary. But in corporatized healthcare, that hierarchy has kind of switched and become blurred. Decisions that should be primarily guided by clinical reasoning are increasingly filtered through appetite-driven structures, cost reduction strategies, productivity quotas, insurance approval, things like that. And this creates a subtle but important shift. Physicians may still know what the right thing to do is, but the systems that they operate in increasingly require them to justify these decisions in terms of cost and institutional approval rather than pure medical necessity. So the concern is not that appetite exists in healthcare, it always has, but the concern is that appetite is beginning to compete with and override reason. Plato also extends the same concern through his distinction between episteme and doxa. So episteme is true knowledge. That's reason, understanding grounded in expertise and in evidence. In the context of medicine, episteme is represented by clinical training, medical research, and physician expertise. It's what allows doctors to move beyond guesswork and make informed decisions about your healthcare. Doxa, on the other hand, refers to opinion. It's based on perception, external influence, and the perspectives around us, rather than stable truth. So doxa is not necessarily false, but it is less reliable because it's not grounded in reason and understanding. In a healthy medical system, episteme should guide decision-making. Physicians use their expertise as the foundation for treatment, while other factors may inform but not override their clinical judgment. However, in corporatized healthcare, there's a growing tension between these two things. And the concern is not that these systems lack logic, but that they operate from a different kind of logic, one that's more generalized, standardized, and financially oriented rather than clinical. So taken together, Plato's framework shows two connected tensions: reason competing with appetite at the level of decision-making, and episteme competing with doxa at the level of authority. While Plato helps us understand the structure within the system, Aristotle helps us understand something slightly different, but just as, if not more important, and that is purpose. In his book, Nicomachean Ethics, Aristotle introduces the concept of a telos, which refers to the end goal or ultimate purpose of a thing. For Aristotle, everything that exists has a natural function, something that's considered good when it fulfills that thing. So when we apply this to medicine, the telos of healthcare is very direct: the restoration of health and the promotion of human well-being. Not efficiency, not profit, not output, but healing of the patient. This is important because Aristotle's framework is not just descriptive, it's ethical. A system is only functioning properly when it's oriented towards its true purpose. In a corporatized healthcare system, however, that telos becomes less clear. While physicians still enter medicine with the goal of healing, the system that they practice within introduces competing ends: financial performance, productivity quotas, billing efficiency, all of those things that I mentioned previously. So instead of a single clear purpose guiding the system, medicine begins to operate under multiple and sometimes conflicting goals. And this creates a structural distortion. Healing the patient remains the stated goal, but in practice, it's often filtered through cost constraints and institutional priorities. From an Aristotelian perspective, this is not just a policy issue, it's a teleological one. The system is no longer oriented towards its proper end. And what makes Aristotle's concept of the telos so powerful is that it's not just about intention, it's about integrity. For Aristotle, a thing is good when it functions in accordance with its purpose without distortion. So in medicine, it's not enough that healing is still the stated goal. The question is whether the structure of the system actually allows medicine to reliably function in the way that it achieves that goal. When administrative systems constantly override and delay clinical judgment, the concern is that the function of medicine is no longer operating in a fully unified way. The system still produces care, but not always through a structure that clearly aligns with its own defining purpose. So when we combine Aristotle and Plato together, a philosophical picture comes to light. Plato shows us how authority becomes divided between reason and external influence, and Aristotle shows us how purpose becomes distorted when a system is no longer fully oriented towards its natural end. And in corporatized healthcare, those two issues converge. Both authority and purpose begin to shift away from the physician-patient relationship and towards institutional structures. So what does all of this mean? Does this mean we need to go back to leaves as bandages and mud as ointment? Not at all. Does this mean that we need to abandon insurance and technology altogether? Again, not at all. That's not the argument here. The argument is not that modern medicine is flawed because it has been advanced. It's that the structure has drifted away from the values that originally defined it. It's important to acknowledge that technology, insurance, and specialization have all contributed meaningfully and benefited healthcare. Medical technology has dramatically improved diagnostic accuracy, treatment options, and survival rates. Procedures that were once impossible are now routine things that we do daily. Specialization has allowed physicians to develop deep expertise in specific fields, improving precision and advancing medical knowledge in ways that would not have been possible in a generalized system. And insurance, at least in its original form, was designed to solve a real problem, making healthcare financially accessible to people who would otherwise not be able to afford it. So none of these systems are inherently harmful. In fact, they're part of what makes modern medicine effective and advanced. The issue is not their existence, it's their degree of control. Over time, these systems have shifted from being support structures for medicine to becoming decision-making authorities within medicine. Technology should support clinical care, but it should not determine whether care is accessible. Insurance should support affordability, but it should not override clinical judgment. Specialization should improve expertise, but it should not fragment care to the point where continuity and patient relationships are lost. So the problem is not advancement. The problem is misalignment. When supporting systems begin to function as governing systems. At its core, the solution is not rejection, it's reorientation. It's recognizing that modern healthcare is not broken because it's advanced, but strained because its structure no longer aligns wholly with its purpose. That's it.
Good job. Well done. Okay. Again, really, really well done. I thought you did a great job of kind of drawing out this evolution that we see within the healthcare industry, in part because, again, like you said, by the time I got to the end of it, I was very depressed. That was a little bit rough. But I thought you did a really good job kind of drawing that out. I was really interested, this in part kind of targets the background of what you did. You kind of painted a very positive view of U.S. healthcare, late 1800s. It seems to some degree very, very idyllic. So I wanted to push against that just a little bit. What would you say, besides maybe the limited technology, what would you say were the real detriments to that particular system, but still defending what you think are the positives within that?
So you're asking what the positives and negatives of pre-corporate healthcare?
Yeah, because you like, for instance, in one of your sections on the patient-provider relationship, you kind of referred to it as historically mission-driven, ethically ideal model. Mm-hmm. So it's almost as if the limitations themselves created a scenario where you had a very, very tight patient-doctor relationship. But what would you perceive as being the negatives in that particular model before it kind of became corporate?
I think the main, negatives of that obviously was that they didn't really have much technology. They kind of had very limited resources, like you said, of things that they could do. And while they had very personal relationships with these physicians and these providers back then, the providers themselves had limited knowledge. And so, yes, they knew more so what was better for the patient based on that patient's life, what is going on personally, what would be best for their needs, but they had less options of what they could give that patient.
Okay. And I thought you did a really good job too of not landing too heavily. Like you don't completely throw corporatization out. So I thought that was an interesting mix. Okay, jumping forward a little bit, you outlined the problem. Want to talk a little bit about potential solutions. Okay. For instance, it was really interesting to read about, like you mentioned, the autonomy of the doctor a lot. How do you increase that? Like, I'm really interested to know what you think the power dynamic in a better system might look, what it might look like. Who at the end of the day kind of gets to call the shots.
Right. Okay. So my, solution, you could say, is I would like to see medical providers, whether that be doctors, physician assistant, nurses, medical people that have practiced in the field, that have lived in the field, that have experienced the field, that knows directly what's going on when these decisions are being made. I would like to see them move on to these administrative positions. We see a lot of doctors, and specifically doctors, but also PAs, SLPs, OTs. We can see that in our College of Health Sciences, that they go into teaching after they're done, after they feel like they've, practiced in the medical field well enough, they go on to teaching. And I would like to apply that to these administrative positions. It's good for us to have these people move on to things like teaching, but also having, physicians, PAs, NPs, all that stuff, move on to these administrative positions, I think would help with that, because they know what's going on in the field. They know what's happening to make these patients need these treatments. And so they have more informed decisions about what patients really need.
Okay. So at least one option is maybe not even so much shaking up the power structure as making sure that you have the qualified people in those administrative roles to make better choices.
Yes.
Okay. All right.
Anywhere near you is
Okay. First of all, I want to say bravo. To be your age and the level of experience you have, to even recognize this as an issue is admirable, and I appreciate that very much. And I really appreciate a lot of the thought you've had in your paper. I've got several things. I won't do this, but we could talk all day about this. It really could.
Yeah.
Because I've kind of lived it. And what I mean is I first went into practice in the late 80s, and there was more of the freedom that you're sort of alluding to. Left clinical practice 2007 and went to the provider of care or payer of care in the state that covers 1 million Alabamians, which is Medicaid. So I've been on the policy end of it also. So that route you just mentioned in terms of the possible solution, I've kind of lived part of that, and I just point that out to say what that does is it makes me appreciate the complexity of all of it. And in 20 years from now, you will have more experience and be able to even see greater complexity. But I hats off to you, because you have unpeeled a lot of the complexity that's there in your paper. So whatever I ask you from here, just realize it's kind of gravy on top, okay? Because I think you did a really fine job. So I really want to stress that. But I am curious about a couple of things. So if you roll back the role of insurance, okay. One of the things insurance does in America is it monitors quality, right? So if you roll back, if you just make them I think the way you referred to them is initially they were just sort of a payer. That's all they did was pay. Physician had the autonomy. They decided insurance paid. Today, their insurance is more interested in the quality than it was in the past. So if you roll back this role of insurance back to what it was maybe in the very beginning, how do you monitor quality?
Well,
Or how do you enforce the
sorry.
monitoring of quality? Might be a better question. See?
So I don't necessarily think that the solution is to go back to what it was originally. I think right now I'm mostly focused on not letting these issues get worse, stopping at where we're at rather than, going back. Because if you ask me, I really don't think that there's a way for us to get back. Or it's going to be extremely hard, extremely challenging for us to get back to that more idealistic sense. And so my goal is more of not letting that control get worse. And so I don't necessarily, see an issue with them monitoring quality. But what my issue is when patients need life-saving care, and it's denied or delayed because the patient, like the circumstances of their life, things that are going on, their economic class, what they can afford, when treatments are denied because of things like that. And it has adverse effects on us because that's when it's affecting, the telos, the purpose, the ethics. We should strive to heal people no matter what it is. And so I'm not necessarily against them monitoring quality, but just making sure that monitoring of quality is not too strict, is not too tight. If that answers your question.
It does, very much so. We exist in a very different world. If you went back to the 1950s or 1920s or even the 1980s, and you looked at the cost of care, it was a fraction of what it is today. I mean, today there are drugs that cost over $100,000, right, and more.
Yep.
Well, there weren't those drugs back then. So to have autonomy over a drug that cost $5, which is what you had back then, versus having autonomy over a drug that's $150,000 is very different. It's very different, right? So, I mean, I think these are factors to consider in this because one of the questions I would ask you is, what value is total physician sovereignty? In other words, your paper points out that insurance has sort of enabled technology and insurance has enabled people to be able to afford the technology, which is true. I mean, it's very true. But if you said, okay, well, the insurance company has, to use an extreme example, no rules, which is not what you're advocating for, right? But to use that as an extreme, then the cost would be unmanaged other than by the physician, right? And the physician might, so the end result would be the cost of insurance would go higher than it is today. So, so the question is, how do you balance the worsening of insurance rates versus physician sovereignty? I don't expect you to answer that. Okay. I just want you to appreciate that's a complicated, hard question. And there are a lot of factors involved in that. And that's really kind of beyond the scope of your paper, but your paper approaches some of that. A few other thoughts I have about the paper in terms of there are other issues involved. I mean, you mentioned insurance companies, and you mentioned at some point in your paper liability, which I think are definitely issues. The role of government is huge. And it's just over 50% of the care in our country is paid for by the government in one way or another. So their policies have an impact. I do want to shift gears a little bit, and that is about morals. And in your discussion between Aristotle and Plato and all of that, I think it sort of got at some of that. Morals in physicians is very important. The existence of morals. If you are dependent in this world that we do exist in, where the insurance companies have perhaps some different motives from just a physician by themselves. Well, the physician's morals, their willingness to stand up to the insurance company, to advocate for their patients, pretty important, right? So the question is, we also exist in a secular society. So the question is, how do you, or do you have any recommendations to enhance the morals of physicians in a secular society? And again, a little outside the scope of your paper, but you've been doing work in this area, so I'm just curious about what your thoughts are about that.
That is a good question. I have thought about that because obviously in the environment that we're in, most, if not all of us in this room are believers in Christ. And we have a moral foundation for why we do what we do. And that's what my paper is based off, is my moral foundation of providing care and doing the best for society. I think that's our job. I think that's our duty. And, being in the healthcare field, I haven't, really dug deep yet because I'm just kind of on the surface level. I don't really have, I don't have my degree yet, so I'm not practicing hands-on with patients. But I've been in a lot of surrounding roles where I get to see other people have this direct care with patients. And you can tell a difference in the patient's outcomes and the way that they view healthcare when they have a provider who has these morals and has these ethics and has these values and makes personal relationships versus providers that are just there because this job makes them money, because, I don't know, they get an ego boost out of, doing this stuff. I don't know, whatever the reason may be for them doing it. And I think that to answer your question, what the solution is to kind of mediate that, again, that's one of those things that's going to be hard because we are in an increasingly secular time period. The rates of not only Christians, but believers in, higher deities in general is decreasing. And so I think that's one of the things that needs to be addressed first, is not necessarily the medical ethics, but the ethics of our society as a whole.
I would suggest you say that means Eden Shipp has strong morals, and therefore I'm very valuable to you, meaning the patient, meaning future employer, because I'm willing to do this. So I just want to encourage you in that regard. One last question, then I'll quit. Okay. So, we've talked about insurance companies, but physicians used to be in, I would call it a cottage industry. They were self-employed, these small practices that you referred to earlier. Well, it's not just insurance companies. I mean, many of the physicians are employed by hospital systems or whatever, or maybe an insurance company directly. Well, they're not the only ones, right? I mean, nurses are employed, PAs are employed, pharmacists are employed, right? So do you see sovereignty issues in these other groups as well?
I do. I guess it's more obvious in physicians because that's kind of like when you think of a medical provider, you think of a doctor. And so I guess that was the, not easier, but I guess easier example, more obvious example, to use. A lot of people don't even know what a physician assistant is. And so it was going to be a whole other, this thesis would have been double as long to do it on a physician assistant.
I just point this out because as a group of people, I think it's useful for us to think, number one, there's the insurance issue. Number two, there's the employment issue. And it's not just physicians. I mean, pharmacists used to be in cottage industries where they had their own practices and their own pharmacies. That's almost none today.
Yeah.
So it's a different motivation. So anyway, I'll stop there. Give someone else a chance.
Eden, I'll just echo what everybody else has been saying. This is a really fascinating paper. You've got a lot of really good insights. I want to double back to something that was said just a minute ago about, you mentioned the idea of care providers who maybe get into the practice for the wrong reasons, like, hey, I can make a lot of money at this, as opposed to the actual telos of healthcare, right, which is to care for the sick. And as I was reading over your paper, just some of the language you kept using over and over struck me, of like the idea of it being a calling, and also with the modern rates of burnout and the paperwork that has to be done. It sounds a whole lot like the modern education system in some ways. And I was just wondering about that, especially after you said that, because the obvious difference there is, we all know what doctors get paid a lot, teachers don't, right? Do you have any thoughts about that connection, like in terms of, because I think it is also a similar conversation where the telos of education is being obstructed in a similar way where there's administrative oversight that's perhaps overstepping its bounds in a similar way to what you're describing here. I'm not looking for like a specific right answer to that question. I just wonder what bells that fires.
It fires a lot of bells.
Okay.
Can you kind of like wrap that all up into one question for me so
I
I
can
know what
try.
to answer?
Yeah. There's a lot of resonance in your description of the healthcare field, which you are obviously more familiar with, and my knowledge and indirect experience with education, and how the telos of each of those, which respectively is to care for the sick and to care for minds, right?
Mm-hmm.
In both cases is being obstructed by administration that may or may not share those same ends. What do you make of that connection? And especially as well with the idea, teachers generally are not known as well paid. Doctors are known as well paid. That seems to influence things as well.
Right. I hope this answers your question. Like you said, teachers are not very well paid usually. And so teachers you find are either doing it because they really enjoy teaching, it's their calling, or because they didn't know what else to do. I would say is probably kind of the two things that you see most, either somebody who really enjoys teaching or somebody that didn't know what else they wanted to do with their life. So they were like, hey, let me go be a teacher. And in healthcare, to kind of parallel that, you've got people that, like myself, could not see myself doing anything other than medicine. Like any other job that you would have me in, I think would make me miserable for the rest of my life. And so healthcare is, whatever part of healthcare it is something I'll be doing. It's, like I would say, my calling. You don't really see people going into medicine just because they didn't know what else to do, because it's not an easy field.
Yeah.
It's not, oh, I'll go get a 4-year degree and then go practice medicine. No, you have to go through 2, 4, 8, 12 extra years. And so I think the major difference would be that, the people that go into healthcare, not because it's a calling, they are not, how am I trying to say this? They're individuals with good work ethic. Not that teachers don't have good work ethic, they do. But, these people can achieve a lot. And if they just kind of flipped why they want to be in medicine, we'd see a lot less of that, if that answers your question.
So like in both cases, it's burnout, but in both cases, the people who want to do the thing for its own sake are doing it well. But for teachers, it's people get into it because they don't know what else to do. And because, you've heard it before, we always need teachers, right? There's a perpetual shortage there. Whereas it's more competitive in medicine, but it's more competitive because there is money to be made there in a very real way. So it's the extrinsic motivations in both cases that cause problems. That's just, I found that fascinating. I'll ask as well, this is something you touch on in the paper, and I would just like to hear more of what you found in your research about it, because it was very evidently hey, here's my paragraph about this, and I could say more, but I don't have time to in the thesis, so now I'm asking you to say more. The difference between the U.S. healthcare system and the general system for European countries.
Yes.
You address that and basically say, European system looks appealing, it wouldn't work. Dig into that a little bit more. Talk to me about why that doesn't work, because that is a really common call today. I mean, you see that with universal healthcare, free healthcare for all, those kinds of slogans that you hear. Right. You seem resistant to that. Why?
So that is something I would say I see it more commonly among my generation and lower. People my age or younger tend to hate on America. They think that America is the worst thing ever, and that, nothing functions right, and that Europe's all great and fine and they got it figured out and everything's good over there. So that's why I used that comparison, because that's
Mhm.
kind of like, again, the most obvious one to make. And like you said, they do have universal health care that's like paid for pretty much everybody over there. And so I wanted to compare those two things. And what I found there is that, first off, the size of Europe is so much smaller than America. I mean, the size of France, it's smaller than Texas. It's smaller than most of our Western states. And so they have significantly less people that they are governing over. So that's one major difference. And the second is that their government is just different than ours. They don't have the same government system that we do. And so the systems that function well in their government are not always going to function well in ours. Because like Dr. Moon touched on, government is a big, big, big part of medical care. A significant amount of our country is getting medical care provided by the government. And so I think that's the biggest thing that we have to think about, is that our government structure is vastly different from theirs. And so the systems that work for them are not going to work for us. Just because they're able to pay for healthcare for their country does not mean that we will be able to. So that's where I was digging in on that
Gotcha.
section.
Do you want to go, or do I have time for one more?
No, you.
Okay. Similar thing. This is hey, you said something about this, say more.
Okay.
I'd love to know your thoughts, because and especially in light of something you said earlier, of it doesn't seem, at least to you, it doesn't seem likely that we can reverse this so much as we can stop it, like halt the spread of the problems. In light of that being such a difficulty, what are your thoughts? And this is a big question that could be a whole other thesis, but in terms of restoring public trust, because there is such an pardon the pun, an epidemic of lack of trust, in outright mistrust of, in many cases, healthcare providers from so many people. I mean, we've seen that time after time in recent memory, right? Like, what does that process look like? Is it just a matter of optics? Is it a matter of policy change? Like, what steps do you think would have to happen there to restore that, at least a higher level of trust, if not full trust the way it maybe once was?
I think that it's really an internal change within the processes first. I mean, we can say that we're going to change these things. We can say that we're going to change the policy, we're going to change the structure, but people aren't going to believe it till they see it. It's getting providers, nurses, PAs, doctors, phlebotomists, pharmacists, all those people in there for the right reasons is the first step. It's a baby steps process. It's not going to happen overnight, obviously. So getting those providers and those people in there for the right reasons first, because I mean, I guess the whole real idea of this thesis is that the patient-provider relationship directs everything. It directs what goes on between the administrative people in the physician versus how patients react to that balance. And so I think getting people in there for the right reasons is the first step. Because like I said, I work in a lab now, but I worked previously as a medical assistant at a practice where there were two very different doctors. One of them was, let me sit in there and hold your hand and explain every single thing to you so that you know exactly what's going on and exactly what we're going to do. And then there was another provider who didn't spend more than 3 minutes in a room with a patient. And he may have seen more patients, but the distinction between the relationships that they had with their patients showed a lot. That provider that was, let me sit there and explain everything and make sure that you're comfortable with this and you know what's going on, his patients came back time and time again. They would ask specifically for him. They were on a first name basis with him. It wasn't doctor, whatever. It was, hey, talking to him like he's a friend. That other person, it was a relationship of fear. They were like, okay, I want help, but he's scary, so I'm not going to ask him questions. And that's where that distrust in the system comes in. And so I think that is the main goal, is getting people in there for the right reasons, people with morals, people with ethics, and restoring that foundation before we change anything else.
Gotcha. Great. Thank you.
All right, we will open things up to the audience for a couple questions. So feel free to ask, and you can direct it how you want to go.
If there's not a change in the system, how do you see it getting worse in the future?
I see a lot of things getting worse in the future if there's not a change in the system. There are so many. I could do 5 different theses. Whatever, theses. Thank you. Okay. I could do like a million different theses on all the things that go into this. But in general, our society, oh gosh, how do I answer this without getting too deep? Oh my goodness. I have the answer in my head. I'm just trying to like not go on a tangent. Restate your question for me. Sorry.
You're good. If there's not a change to the system, how do you see it like getting worse?
Okay, so I see it almost like, this sounds so extreme, but that there's not going to be a relationship at all. It's not going to be, in-person doctor visits with all of this, like the processes that we have now. It's, I hate to use this, but Dr. Google, let's use technology to solve all these problems. There's going to end up being no relationship with the healthcare system because the trust will keep declining. If that answers your question.
Teledoc with an AI doctor.
Yeah, that's the whole other part. That's why I was trying to not go on the whole like technology, AI, quality of education and providers, because that's a whole other thesis that I could do. So.
All right, good job.
Am I done?
All right, the committee needs just a few minutes for housekeeping items, so don't disappear. We'll come back and we'll say nice things. All right, one of the great traditions about GB is that the class environment, let me turn that off so it doesn't. The class environment, I know what I'm doing. I don't know. I'll just do it like this. There we go. Okay. The class environment itself is very, very different. So at the end of every GB class, the students have the opportunity to offer words of encouragement or words of honor to each other because they've been learning with each other over the course of the semester. Well, your faculty want to be able to do that too. So,
Yay.
Edie, your persistence in daring to question, to set your perspective alongside others' views, and to assess them with hard fought for objectivity, to be a lover of truth, as Plato describes, marks you as courageous, and it has blessed our discussions. Congratulations. Well done.
Thank you.
And then we're going to listen to Audrey as she tells us what to do.
Okay.
Okay.
I'm gonna hold on.
There you go. Woohoo. All right. Well done. Well
Is
done.
that it? Are we
Thank you,
done?
everybody, for being here.
Yay.
Thank you.
Thank you. Thank you.
Well, I wish you were